Hey everybody! As you can see, this video is going to be a little bit different from our normal. Colorado is in a deep freeze. We may not be able to get out on the roads and film our adventures this week, so we thought we'd do a video that we've been wanting to do for a while now. As you can see by the title, I'm going over what I do as a mother-baby travel nurse. First, I want to give a little bit of a background about myself. So, I've been a mother-baby nurse for 3.5 years. That's all I've done as a nurse since I've graduated college. And what a mother-baby nurse is you take care of the mom and the baby after delivery. I don't do any of the labor and delivery stuff. That freaks me out, and I probably will never do that. I just do after birth. So as a mother-baby nurse, I am qualified to take care of mother-baby, like I said, the mom and the baby. I'm qualified to take care of GYN patients, and I am also qualified to take care of mamas that haven't delivered yet but are not in active labor or the baby's not in immediate distress. And I'm also qualified to do a level 2 NICU. And what that means is the baby is not the sickest baby in the NICU. They're the healthier babies in the NICU. They mostly need feeding help. They need to grow, a little bit of oxygen issues. I can take care of babies with low flow oxygen, and that is about it. But for this video, I'm just going to keep it simple and go over a routinely mother-baby night. Okay, so to start off, me and Sam both work nights, and we usually wake up around 4 o'clock. We love to wake up a little bit earlier just to get our coffee in our system, wake up a little bit before we have to worry about getting dressed and getting ready for work. So we drink our coffee, make our dinner, eat dinner, and then we get ready for work. And we usually leave for the hospital around the 6-ish hour, depends on how far away we are from that hospital. As I said earlier, we are travel nurses, so we are at a different hospital every 3 months. So we usually leave probably around 6:15, 6:30. Once I get to the hospital, we get report. We give bedside report from the day nurse to the night nurse, and we make our rounds on our patients. The day nurse tells me updates on our patients, things I need to worry about throughout the night, things like that. Just a brief overview of your patient. After I get my rounds on my patients, I sit down, check their chart, check their orders, make sure I have all my plans for the night laid out on my little clipboard that I like to keep, and I have a basic understanding of what my night's going to look like. Before I get started seeing my patients, I like to get the supplies that I might need, such as Band-Aids, flushes, alcohol swabs, anything like that I just like to keep in my pocket. After I have my night kind of planned out, I start to round on my patients as soon as possible. A lot of hospitals don't have a nurse's aide to get vital signs, but the one I'm at this time does. If not, I'll get the vital signs and do the mama and baby assessments. A mama assessment basically includes an overview from head to toe assessment, checking her heart and lungs, checking her bleeding after delivery. That is a big issue with postpartum moms. The typical postpartum nurse checks the patient's fundus, and what that is the top of the uterus, making sure that it's firm and she's not at risk for bleeding after delivery. Check her gastrointestinal system, check her IV side if she still has one, check her fluids if she still has fluids going. A lot of the times postpartum moms right after delivery have Pitocin running, and that's to help with controlling of the bleeding from the mama. You'd of course check her legs. A lot of mamas are at risk for swelling, and most of them do have swelling. Make sure she doesn't have any signs of a blood clot, which is a big risk for a postpartum mom. They're one of the highest risk patients for blood clots. Check her pulses, make sure she looks good from head to toe. And a big priority that I as a nurse have to look out for. A lot of mamas have blood pressure issues. That's another big thing that a postpartum nurse deals with. And there could be a lot of other issues, but those are the main ones. So vaginal delivery assessments are a little bit different than C-section assessments. If you do have a C-section patient, you would of course look at their incision, make sure it's healing well, making sure that patient can walk, because they're in a lot of pain a lot of times and they have trouble walking the first couple of times, making sure that they don't have any complications after surgery. And a typical baby assessment includes just looking over the baby, making sure that everything looks right. Because as you know, they were just born. You're the first person that looks over this baby to see if there's any abnormalities. So you'll check the baby's heart, make sure there's no murmurs, check the baby's lungs, make sure that the baby is breathing fine. That is a typical issue with newborn babies. They can have some breathing issues. Check the baby's belly for bowel sounds and make sure the baby can pee and poop within the first 24 hours of life. Check the baby's reflexes, make sure the baby has an intact neurosystem. Check the baby's head. A lot of babies come out their head's all crazy, as I'm sure a lot of you have seen. So you just make sure that everything looks right with the baby. Of course, they're gonna have those abnormalities at first, but make sure there's nothing serious upon your assessment. And those assessment things are just a brief overview. Of course, it's more in depth that I'm not gonna go through on this video, but those are the typical things that you would look for. After I do my assessments, I typically go back to the chart and start charting on my patients. As a nurse, you have to chart basically everything. If you did it, you must chart it, or it's not legally done. That's basically the life of a nurse. So you chart everything that you do. After I do my charting, by the time it's around 9 o'clock, if my patients haven't called on me yet, I'll go ahead and round on them again and pass their routine meds. A lot of meds that postpartum mamas are on are things like stool softeners, prenatal vitamins, iron, because they lose a lot of blood, so they're going to need an iron replacement. If they have any blood pressure medication, if they have any medication for bleeding issues, and those are typical meds that you would find in a postpartum mom. The babies usually don't have any meds other than right at birth they do get vitamin K to help with their clotting, erythromycin eye ointment to help with bacteria in the eyes, and if the mama wants it, they can get their first hepatitis B vaccine. But that is typically done right after birth, and I wouldn't be giving that routinely on mother-baby. But sometimes you can, depending on the hospital. After the med pass, it's usually when the night starts to slow down a little bit. This is when I really do the main part of my charting, and also throughout the night, you're helping the mom feed the baby appropriately. A lot of mother-baby nurses are trained to help with breastfeeding. There are specialized nurses that are lactation consultants, but usually a mother-baby nurse has enough knowledge to really help the mom and the baby feed with breastfeeding and, of course, bottle feeding. A lot of the times babies in their first couple of days of birth have a lot of feeding issues, and the mom's just getting used to how to feed the baby and the baby's learning how to feed, so that is a typical task that I take care of throughout the night. A lot of the times after midnight, this is when the nurses are allowed to grab the babies, bring them to the nursery, and check their weight. We do daily weights on babies. A lot of newborns do lose weight the first couple of days of life, which is very normal. You just want to make sure that their weight loss is within 10% of their birth weight. If they are old enough, after 24 hours, we do what is called newborn testing. A lot of hospitals call it a little bit different. So what that is, you check the baby's jaundice level. Most newborns have some degree of jaundice. We just check to make sure that it's not too high of a level to where we have to treat. If you guys have ever seen those movies where the babies are under the blue lights, jaundice is what those blue lights are treating. And I will put a definition of jaundice right here, so you guys, if you don't know what that is, you can read up on it. If the baby's level is high, of course they will have to be put under the blue lights, and they are allowed to stay on the mother-baby unit. It's not like a high-risk thing to where they will have to go to the NICU. They're just put on the blue lights in the mama's room. Another thing we do at this time, as long as they're over 24 hours old, is check for the congenital heart disease screen. And what this is, you check the baby's oxygen level in the right hand, which is measuring the blood flow before it reaches the heart, and then on one of the feet, which is checking the blood level after it is pumped out of the heart. So you're making sure there isn't a big difference between the two, which would indicate that the baby has a heart disease. Another thing we do during this time is, as long as the baby is 24 hours old, of course, we check the newborn screen. And this test is checking for metabolic and blood disorders from the baby. We usually prick the baby's heel and get 5 blood drops, and it's sent off to be tested for all these disorders that a baby can be born with. Also, after 8 to 12 hours, depending on the hospital, the baby is eligible for their first bath. So either the nurse or the parents can do their first bath. This is when a lot of education happens on bathing the baby. And a lot of the times the nurse does the first bath because the baby is at risk for the temperature dropping, and a lot of the times it is done under the warmer in the nursery. That can take most of your night up, between 2 to 3 babies a night. Some hospitals, the day nurses do it as well, but most hospitals that I have been at, the night nurses do it because nights are a little bit slower than days, and the night nurses have a little bit more time to take care of the baby's things. Of course, in this time you would be doing vital signs at midnight as well, and then 4 o'clock. And of course, like I said earlier, helping with feedings throughout the night and med passes if there are any during that time. Usually I like to take my lunch break between 1 and 2. I feel like that's a good time because it is a 12-hour shift to have a little bit later lunch. It holds me over for the rest of the shift after, and that's just when I feel like I start to get the hungriest. So lunches are usually a 30-minute break, and then you're back to work. Usually around the 4 a.m. hour is whenever you would start to draw mama's labs. Typical labs include a CBC, which measures the blood count, and if the mom is at risk for like blood pressure issues, you may draw a CMP, which is measuring electrolytes, things like that. Some hospitals, the lab techs will draw it, but also a lot of hospitals, we as a nurse have to draw those labs on postpartum. Towards the end of the shift, between 4 and 7, usually a little bit slower, you're starting to round up the shift, making sure your patients are settled. Of course, throughout the night, you'll be passing pain medication as often as the patient needs and what is ordered. And then you're basically letting your patients sleep if they can. Most of the time they don't sleep though. By that 6 o'clock hour, I start to get all my paperwork together, make sure I'm wrapping up the tasks that I need to be finished before the end of my shift, and getting ready for report for the next nurse. And then the day nurse comes on, and I give report, bedside report, like I said earlier in the shift, then I'm ready to head out. So that is what a typical night looks like for me as a mother-baby travel nurse. Now that you know what my night routine is, I'd like to talk a little bit about travel nursing as mother-baby specialty in general. So mother-baby is really a well sought out specialty for a nurse, and as a travel nurse, the jobs aren't as widespread as you would see like a ICU nurse, Medsurg nurse, because a lot of nurses like to stay on the mother-baby specialty and don't really leave that specialty. So as a travel nurse, there's not very many options in hospitals like you would see in other specialties. With that being said, I have been a travel mother-baby nurse for about 1.5 years. Jobs are a little bit scarce, but it's not impossible to keep traveling nonstop as a mother-baby nurse. Me and Sam do like to take a lot of time off in between our assignments just for preference, so we haven't felt the need to have back-to-back assignments. It is definitely possible. You just have to find an agency that has a lot of mother-baby assignments available, because most agencies have different hospital access to jobs. Also, as a mother-baby travel nurse, you really can't be picky about where you go, because like I said, the jobs are just kind of sparse and you just go wherever you're needed. Traveling as a mother-baby nurse is pretty simple because postpartum patients are all the same wherever you go. You just might have a different schedule at different hospitals as far as like vital signs go, just the normal routine of the night. Like I said earlier, some day nurses may do the baby labs and stuff, and some hospitals, just the night nurses do it. So it just depends on what the hospital does. Patient care in general is very the same though. Usually as a traveler in general, you are floated first to different units. As long as you have the experience to float to those units, you would be floated typically to a NICU unit, like I said, to take care of feeder grower babies, which are the less sick babies. You can float to a labor and delivery unit to recover postpartum patients, or to take an antepartum patient, which are the mamas that aren't in labor. I've also been floated to like Medsurg units to sit for patients that have psych issues and just need a nurse to sit in the room at all times to watch them. Or you can be floated to any other units to task, to help with vital signs, help with the desk, things like that. Never as a mother-baby nurse have I been asked to take patients that I don't feel safe taking. Usually in your interview with your hospital, you can ask what their floating guidelines are, and I usually always include that in my interview. Let us know if you like videos like this, because we think Sam might do one about his Medsurg nurse routine. And of course now he's pretty much a COVID nurse, so we can talk about that a little bit too. So just let us know if you'd like to see him do one of these. And also don't forget to subscribe. Bye guys.